Thank you so much, Nora. Those are really kind comments. I will say that I feel very privileged to have the program that we have at Stanford. We have a Center for Lymphatic and Venous Disorders that I've run for about the last 25 years. And we're about the only program, maybe in the world, but certainly in the United States, where we both diagnose patients, take care of patients, do clinical research, do basic research, have a lot of teaching functions. And as you'll hear in a moment, we're trying to solve a really big problem in this topic area. Lymphedema is a funny medical problem because the world treats it as a rare disorder, but it's not rare at all. We think that 10 million people in the United States have lymphedema, and in the world at large, 90 million people. This is a very common problem that generally gets overlooked or somehow is given short shrift. And so I'm really pleased that you have come tonight to hear about this. It's a topic that is very exciting to me. I am very thrilled that the last time we did this, back in 2012, the video was uploaded to the Stanford library on YouTube. And as of today, it's had something like 70,000 hits, which, if nothing else, it kind of made me a star with my kids. But in addition, it's wonderful that it's reaching so many people because, as I've said, this is such a common problem. So I'm going to start with a cartoon to point out that, unfortunately, lymphedema is not a very hip disease. It ought to be. And part of this talk tonight is about changing that perception with the advances in research and in clinical care. Now, there's a good reason why it's not a very hip disease. I did this study, a semi-formal study, now more than 10 years ago, in trying to find out in the United States and in North America in general, how much education do doctors really get about all of this, because the patients feel like their doctors don't know anything. And it turns out, as you can see from this graph, that about 1/4 of the doctors in North America have heard about the lymphatics in medical school for something between 15 and 30 minutes in a 4-year medical education. So if any of you have had the opportunity to see a doctor about lymphatic problems, maybe you won't be as surprised that the doctor most likely said, "I don't know what's wrong with you," or "There's nothing we can do," or "Why are you asking me about this?" This is the kind of reception that our patients unfortunately have received. Now, I want to show you paradoxically why that shouldn't be the case. I've had the good fortune to co-write this book, which is a textbook on lymphedema. We wrote the first edition about 6 years ago, and we were invited by the publishers to revise it, and it just came out in January of this year. You'll notice we called it a concise compendium. That means not every word we could say, but just what we think is the essentials. And this book has about 1,000 pages. There's a lot to know. And the fact that somebody goes through a medical education and gets 15 minutes on this is really quite a travesty. So we're here tonight to rectify a little bit about that. So, as I've said, the lymphedema is a condition that, while common, suffers a little bit from problems of name recognition. I want to, first of all, try to simplify this Latin term so we know what we're talking about, and then I'll go into more detail. So, edema is the Latin word for swelling. So a part of the body or all of the body can swell with a variety of things. We have myxedema, we have hydrostatic edema, we have lymphedema, we have venous edema. There are a variety of things that cause swelling. So lymphedema is swelling of a part of the body with a body fluid called lymph. So before we talk about lymphedema, I really do need to introduce you to the lymphatic system. Let's talk about lymph, what it is, what it does, and why we should be interested in it. So these microvessels that run throughout our body are what we call the lymphatic circulation. And what you're looking at here is a typical vessel under the microscope. I want to show you how elegant these vessels are, because unlike the blood vessels, that require I'm a cardiologist, so I'm not denigrating the heart, but the heart is a central pump that drives the blood all the way through the circulation. But in the lymphatics, the vessels serve as the heart. They actually pump the fluid themselves through their own ability to contract. So this is taken from a rat, but you can see this lymphatic vessel contracting and relaxing as it propels the lymph through this part of the circulation. And this is all under its own steam. Very, very elegant system. Now, I like to talk about the lymphatic system to people who don't understand about it in the metaphor of a brick wall. So if I ask all of you to look at this picture, and maybe I ask you individually to describe what you see, I suspect that pretty much everybody would talk about these rectangular-shaped objects. They're maroon-colored, they're stacked on one another in an overlapping fashion. All of that is true, but I suspect that very few of you would take the time to describe the white mortar that sits between those bricks. But in fact, if you don't have that mortar, all you have is a pile of bricks, right? So what makes the wall is really the invisible part. It's the part that holds it together. And that's what I think is the function of the lymphatic circulation. Now, the lymphatics are part of the general circulation, and they are required to transport about 1% of the circulating volume that goes through any transit of the blood vessels in any minute or hour or day. As fluid goes through that circulation, about 1% of the water will leak out into the tissues. It will combine with chemical substances that are present in the tissues, and then the only way it can get back to the heart is through these lymphatic channels that reconstitute the volume of the blood. But what is a little bit less well appreciated, but maybe almost more important, is that the lymphatics are also part of the immune system. So you probably have heard about lymph nodes. Lymph nodes are part of the lymphatic circulation. The lymphatic vessels run through the lymph nodes, much like the train tracks run through the stations as you travel from west to east, from Oakland to New York. And it is that transit through those lymph nodes that allows the immune system to understand what is the composition of the lymph, which in this context is telling the body if there is a threat of infection, invasion, toxins, any threat that requires an immune response is delivered, the message is delivered to the immune system by the lymphatics. So you can understand this is a very important system. It sits at the crossroads of two of the most vital functions that we have in biology. Now, there are a lot of facts here that I'm not going to bother you with, but I'm going to superimpose a little bit of a summary and tell you that through this lymphatic network, we have about 25 milliliters per second of flow. If we map out the lymphatic network, like the train tracks, there are 3,500 kilometers of lymphatics within the human body, and at any one time they contain 2 liters of fluid. That's about 40% of the amount of volume that is in the circulation itself. So this is not a trivial part of the body and not a trivial part of the circulation. I won't have time to talk about this tonight, but just to pique your interest and maybe some outside reading, I will tell you that for me, the importance of the lymphatics is not only about lymphedema, but about health and disease in general, because we now know, as you go down this list of diseases and categories, every one of these represent a context in human medicine where the lymphatics either contribute to the development of the disease or to the treatment of the disease, or both. And in the years to come, I predict, just as we've refocused our attention on the mortar and the brick wall, medical science will refocus its interest on the lymphatics and use this as an avenue to control metastatic cancer, autoimmune disease, chronic infection, coronary artery and other cardiac diseases, and even, most excitingly and most recently, probably Alzheimer's disease and other neurodegenerative diseases in the brain. So as doctors, we tend to think of every organ in the body as having a unique disease or set of diseases that characterizes the system failure of that organ. So this is just a simple list of a few of them. If the heart fails as a pump, we have a disease called congestive heart failure. If the pancreas fails to produce insulin, we have a disease called diabetes, and so on. Well, when it comes to the lymphatic system, and now we're coming back to that term of lymphedema, when the lymphatic system fails, either regionally or centrally, we develop the end disease, the system failure that we call lymphedema, or swelling based upon the pathological accumulation of lymph. Now, because we have lymphatic vessels anywhere and everywhere in the body, any part of the body can theoretically be affected, including the head and the neck even, and this is not at all an uncommon problem. And in aggregate, this set of disorders affecting different parts of the body is lymphedema. But as I've said, when the patient comes to the doctor, even today, even in 2018, very often this is the perceived reception. I don't know what's wrong with you. What are you asking me about? Why don't you just live with it? There's nothing you can do. There's nothing, we don't know how to evaluate it. We don't know how to treat it. All of which are not correct. So let's talk a little bit about the presentation of lymphedema. So the first thing I want you to know is that lymphedema comes in two broad flavors, like vanilla and chocolate. The vanilla flavor is what we call primary lymphedema. It means that the individual is pre-programmed to develop lymphedema based upon some genetic aberration that has perhaps either been transmitted from a parent or might appear as a new mutation or might be genetic and we don't even know what the cause of it is. Now, primary doesn't mean congenital. It includes congenital. This is a child who has had congenital lymphedema, now is a toddler. But primary lymphedema can appear at birth, when we do call it congenital, or it can appear in adolescence, or it even can appear after the age of 35, all on the basis of a problem in the blueprint for the development or the function of the lymphatics. But it's part of human biology that the time of appearance will be dictated by what the underlying problem is. But here you can see the clear-cut genetic nature of this problem. This is called Milroy's disease. Probably if you ask one of those doctors who got 15 minutes in medical school, they probably will know this term. This is a pretty well-known term, and this is the most common form of primary lymphedema, in which 50% of the children of an affected individual will also be affected. So here you can see the father and the child have exactly the same problem in the legs, and we now know what the genetic defect is in this condition. So this is a general summary of the kinds of primary lymphedema that we see in the United States. Primary lymphedema affects slightly under 50,000 people. So this one borders on a rare condition. Lymphedema overall is not, but this is a rare subset. As I've said, it comes in three broad flavors: the type that appears at birth, which represents somewhere between 10% and a quarter of the primaries. The lymphedema precox is the one that appears at the teenage years or into young adulthood, and that one it represents the predominant form of primary lymphedema. And then about 10% or slightly under 5,000 in the United States have what called lymphedema tarda. That's Latin for late lymphedema, and it basically means coming on after the age of 35. However, much more common than primary lymphedema is acquired or secondary lymphedema. And in the United States, the predominant cause of this, or it has been historically, cancer treatment. Not cancer itself, but the staging of cancer and the control of cancer, which involves removing lymph nodes. Remember, we said the lymph nodes are there as part of that circulation, and they represent the place where the cancer wants to migrate. Again, that immune relationship between the lymphatics and the lymph nodes, and the cancer cells go through the lymphatics and they end up in the lymph node. The surgeon needs to know if the lymph nodes are affected or not, which will determine subsequent treatment. But the end result is, for these cancers listed down below, there is a very substantial incidence of lymphedema that occurs as a byproduct of treating and curing the cancer. It depends on which cancer you're looking at. For breast these days, probably between 15 and 20% of survivors will ultimately develop lymphedema. For melanoma, it might be as high as 40 or 50%. if there has been lymph node excision. And for some of the gynecologic malignancies, it's about 30 to 40%, and comparable numbers for many of the others. I will tell you that in the world at large, I mentioned there are 90 million people in the world. Most of those people have a chronic parasitic infection that destroys the lymph nodes, and that's called filariasis. Thankfully, we don't have that infection in the United States, so we really don't need to think about it. But increasingly in my practice, what I see eclipsing cancer as a problem leading to lymphedema is obesity. And I would say that's pretty much the number one category that I see of new diagnoses today. Well, in the context of cancer, we need to talk about surveillance, because if we know that somebody's being treated for a cancer and they have a 15 or 20 or 30 or 40% chance of developing lymphedema, we need to know who's going to do that and when, and theoretically we want to treat as early as possible or possibly even prevent. And I'm going to show you why this becomes important. This is a survival curve of individuals who've had breast cancer treatment with surgery and radiation. And in this particular study, if you can read graphs like this, you can see that about 15% of those patients ultimately develop lymphedema. But you'll also notice that close to that zero on the left-hand portion of the graph is when all of the lymphatic damage occurred. But you can see that the onset of lymphedema occurred at a variable rate in the individuals. About 90% of those who will develop lymphedema will do so within the first year, but the other 10% will happen over the remainder of their lifetime. And there is actually no time point effectively where that number drops down to zero. So this curve that looks like it's flattening out never really flattens out completely, and that's why we have to do a lot in patient education and in surveillance, but we're particularly concerned about that first year where 90% of the problems are going to occur. And part of the issue is, as patients become much more educated and self-educated, because often their doctors aren't telling them that this could be a problem, this engenders a lot of fear, because even if you know the odds are better that you won't develop lymphedema than you will, you still have to live with the unknown threat hanging over your head. And there really historically has been nothing to provide reassurance to say, okay, you probably don't need to worry quite as much. We do have some new technology, thankfully. This has been developed over the last 15 or 20 years. I started using this technology actually in animal models that I studied, but now it has progressed on to patients, and it's called bioimpedance spectroscopy. And basically, it is based upon the fact that as tissues accumulate water, it becomes easier for an electrical signal to travel through them. You all know you're not supposed to talk on the telephone in the bathtub, right? Because that's a dangerous thing to do, or stand in a puddle of water if there's lightning out there. So electricity likes to go through water, and if you have a limb that's at risk and you're monitoring it over time, and sorry, is that something we need to pay attention to? No. Oh. If you're watching this limb and over time it becomes easier and easier for the electrical stimulus to go through the limb, that's a sign that the limb is accumulating water, even before we can detect it, before the patient can feel it, before the doctor can see it, and that allows us to treat at the very earliest time point. And in fact, we've been successful actually at reversing the process if we initiate aggressive treatment at that very, very early time point. So here at Stanford, we have a cancer surveillance program for lymphedema. We're trying to identify the cancer patients as much as possible, the ones who will be in the high-risk category because of the treatment that they're going to receive. We try to identify them actually preoperatively, if at all possible, to get a baseline measurement, but if not, at least as early into the treatment as possible. And we monitor them on a quarterly basis during that index first year so that we can initiate treatment in a preclinical mode and possibly reverse the problem. It also allows us to give certain lifestyle recommendations, not just for the ones who become positive. But for everybody, I put this here facetiously to remind me that we tell people that they have to be very careful, those that are prone to upper limb lymphedema, very careful in the kitchen, because any injury to the skin can be a triggering event. It can be taking something hot off the stove and burning the hand, or it can be puncturing part of the hand with a cutting knife or anything of that nature. Also, we warn people about the risks of air travel, because when you're in the airplane, the cabin is only pressurized to 7,000 feet. We all kind of get swollen feet when we sit in the plane that reverses in 5 minutes after we land. But if you have a limb that's at risk and it gets swollen, it may not come back down again. So we have certain strategies we like to follow to try to prevent that problem. When we examine the patient with lymphedema, what we're looking for in the early stages, not just lymphedema, but any edema, is this finding that's called pitting edema. That means I took my finger and, like the Pillsbury Doughboy, I pushed into the tissues and I pushed some of the water out of the way, and I was able to create this pit that will gradually fill in over 1 or 2 or 3 minutes. This is a sign that there is fluid in the tissues, and this is the part of lymphedema that we can treat through the mechanical means that we currently have to treat lymphedema. But unfortunately, and one of the reasons we emphasize early diagnosis and treatment is there is a tendency for lymphedema to lead to structural changes in the limb, and eventually that pitting quality is lost because we get overgrowth of cells, we get deposition of proteins, we get deposition of fat under the skin, and eventually the limb that used to be like a little bit of a water balloon that can have the fluid mobilized out of it becomes a heavy, immobile limb that no amount of external compression will change. And this is, if you want to think of it, the heartbreak of lymphedema. This is what we're trying to avoid. And when I come back to the research part of things at the end of the talk, I'll tell you what we're trying to do about this. But for that purpose, the International Society of Lymphology has given us a staging strategy for lymphedema. It starts with stage 0, which would be the person who comes into our surveillance program, has an abnormal reading, but the limb looks completely normal. That's stage 0. Stage 1 is when we begin to see that pitting, but it resolves completely, as it does initially, by, for example, lying down and having a night's sleep. But eventually, because we see that transition to the tissue abnormalities, that ability to resolve with elevation becomes progressively lost, and by the time we get to stage 3, the limb is very, very disfigured and abnormal, and no amount of any intervention is really going to change much. So this is actually gives you an idea of how that progression goes. And unfortunately, I see way too many patients who come in with stage 3 lymphedema, and there's very little that we can do about that. But at whatever stage we see the lymphedema, I want you to know that there's a list of biological changes or pathological changes in the limb or part of the body that's affected. And all of these things that I've listed on the right-hand side are things that we know happen clinically and psychologically to the lymphedema patient. They're no longer able to do the work that they are accustomed or trained to do. They lose productivity. They feel socially isolated. They have erosion in self-esteem based upon the changes in appearance that they experience. Their body image becomes impaired. There is documented problem of depression and anxiety. And all of these are related to everything that I think is on the left-hand portion of the slide. So to fix what's on the right hand, we need to fix what's on the left hand. So we start with diagnosis. Before we can do any treatment, we need to know what we're dealing with. Now, again, I put this in a little bit facetiously. You can't list your iPhone as your primary care physician. We know that we're relying increasingly as medical consumers on the internet for information, and I will tell you that many, many patients come in, not just in the lymphatic practice, but also in my cardiovascular and general medical practice, with a preconception of what the problem is based upon their reading on any of the number of sites that will provide this kind of information. The problem is you do need to be able to distinguish what has the appearance of something from what really is something. And in the case of lymphedema, that can be done at the bedside with a well-trained clinician. But as we've said, if there was only 15 minutes in medical school, chances are the clinician may not be very well trained and wouldn't distinguish, lymphedema from a caboose or whatever it might be. We do have imaging tests. I don't rely on these very often at all because, as I say, I think the exam often helps us. But this is what we think of as the gold standard for lymphedema. It's called lymphoscintigraphy. We do this test at Stanford. We do all of the tests I'll be talking about. And this relies upon the injection of a substance, in this case, into the hands. Those big starbursts are where the material was injected. And then we watch the material as it ascends the arm through the lymphatics. On the patient's left, which is closer to me, everything is normal, but on the right side, we don't see any lymph node accumulation of the material, and we see very deep staining of the tissues, both of which are diagnostic of the fact that this is in fact lymphedema. This is what it could look like in the legs. This is a very abnormal study. This is actually one of those causes of primary lymphedema that appears in adolescence, called lymphedema distichiasis. We also can rely on MRI in many cases, but it's more helpful when we're trying to see the large central collecting lymphatic structures. So what you see here, this is actually a normal volunteer, but that vertically ascending white stripe that goes from the middle of the field upward is called the thoracic duct, and that's the equivalent of the aorta in the lymphatic circulation. It's the biggest vessel right before the lymph rejoins the blood circulation, and that's a standard MRI with contrast. The newest imaging that we do, and this has applications either in research or increasingly in some of the surgical applications, is called near-infrared fluorescent imaging. And here, again, we're injecting into the skin, but instead of relying on a nuclear radioactive kind of imaging procedure, we're using the fluorescence of the material under a near-infrared light source. On the left-hand side, farther from me, is a normal study where you see the normal channels ascending the leg. And on the right is one of those cases that I mentioned earlier of Milroy Disease, where you basically see pooling of the material in the tissues because the lymphatics are not taking it up appropriately. Well, one of the issues that comes up daily, weekly in my practice is trying to decide what is the cause of the lymphedema, or is it something that looks like lymphedema but really isn't? So that's really much more important in a diagnostic realm than confirming lymphedema through an imaging technique, although all those things I just showed you are feasible. One of the things I end up looking for a lot, depending on my clinical evaluation, is whether there is a suspicion that the initial cause of the edema and the overload of the lymphatics is actually an obstruction of a vein. And the reason this is important is that while we can't realistically alter the lymphatic damage, if the surgeon has taken out a bunch of lymph nodes and the lymph circulation isn't working well, we can't restore that by today's technology. But if a vein is obstructed, we do have technology to deal with that. So this is a condition that I see commonly in patients who come in with lymphedema of one leg, and this is actually showing an obstruction of the vein ascending from the left leg up to the inferior vena cava by the overlying aorta. And when we make that diagnosis, we can put in a stent and actually alleviate that obstruction. If we do it early enough, we can halt the progression of the lymphedema and maybe even cause it to reverse. So the patient can look like they have lymphedema of one leg, and they do have lymphedema, but it's on the basis of a correctable venous problem. And there are a variety of these that we look for and a variety of techniques that we use when we find it. Another condition that I'm seeing increasingly, partly because I was interviewed about this on NPR earlier this year, so now everybody is finding me for this, but this is a condition called lipedema, which superficially looks like lymphedema, but in this case, two things are true. Number one, the feet are completely spared, which is very characteristic of lipedema, and this large increase in the size of the legs is based upon abnormal deposition of fat from the hips down. Now, typically these patients have a normal-sized trunk, normal-sized upper extremity, and this condition affects only the legs. It is actually a lymphatic disorder. It's just a different kind of lymphatic disorder. What you see here are the factors that I think schematically lead to the progression of the structural disease in lymphedema, and all of these are true of lipedema except the immune dysfunction. For some reason, because the lymph nodes are not affected, these patients are not prone to recurrent infection. They're not prone to all of the immune defects in the limb that lymphedema patients get, but they have everything else fundamentally. It's just two different routes to the same endpoint. When we do imaging of lipedema versus lymphedema, what we see is that in both cases there is a deviation from the normal pattern, but lipedema has abnormal lymphatics that are abnormal in ways that are different than people who have lymphedema. This is a great unsolved medical mystery at the moment. I've been doing some research with some colleagues at other institutions, and we think we may have identified some valuable biomarkers for lipedema that are distinct from lymphedema, and that may open the door for us to understand a little bit better about why people get this. But for tonight, I just want you to know that this exists in part of what we call the differential diagnosis. Current clinical practice is based upon using physical measures to help the lymphatic system be as active and efficient as possible. We rely upon a technique that includes lymphatic massage, application of bandaging materials that serve to amplify the lymphatic contractions. I showed you the lymphatics contracting in the rat earlier on. Well, putting this bandage on over the swollen limb amplifies the activity of the residual lymphatics in that limb and allows them to be more efficient and effective. And doing this repetitively will allow us to bring the swollen limb down as small as is feasible. We have to do this with exercise because it is movement of the limb under the bandage that allows that lymphatic contractile augmentation to occur. And the end game is to get the patient into a compression garment that will preserve the benefits of that acute treatment, which may take as much as 6 weeks of seeing a lymphedema therapist 3 to 5 days a week during that period of time. Once the limb stabilizes at a 50% reduction or 80% reduction or 30% reduction, whatever we can accomplish, then it is the job of the stocking or the sleeve to preserve that benefit and make sure that it doesn't recur. This is the key step. However, the biggest mistake that I see in clinical practice is, again, those 15-minute doctors sort of know that you're supposed to put a sleeve or a stocking on a lymphedema limb, but they don't realize that you don't do that at the start of treatment, you do that at the end of treatment. So putting a stocking on somebody who comes in with a new diagnosis of lymphedema is only going to possibly ensure that the limb doesn't continue to get larger, but it won't do anything to reduce the size of the limb. So that's a big problem that we need to rectify. We now have a variety of compression devices that we can rely on. I'm increasingly fond of these more semi-rigid devices that can be adjusted with Velcro straps. They're a little bit easier to put on, particularly for people who are obese or have joint problems, arthritis, or they're elderly and have difficulty bending over or have difficulty with strength with the hands. But, of course, they're bulkier and a little more difficult to incorporate into normal clothing wear. We do have nighttime garments that can be used, but they're not necessary for everybody. They are used under certain circumstances. And we have pneumatic compression devices that can be prescribed for home use to augment the benefit of everything else that has been done. These are not standalone devices, but in the proper circumstances, they can really help to improve the treatment outcome and to maintain it much more efficiently. Very interestingly, I participated in a series of health economic studies related to these pneumatic compression devices, which are admittedly costly, and we found that when you incorporate one of these into the care of a patient with lymphedema, per year, including the cost of the device, you save on average about $12,000 per patient. meaning that when you get better control of the lymphedema, they go less to the emergency room, they have less infections, they need to go less for recurrent visits to the physical therapist. All of the clinical categories in which we do outpatient care for lymphedema patients is reduced with this economic benefit when we utilize the pneumatic compression devices. The goal is to get people, of course, actively back into the workplace and active and socially functioning in the home. It doesn't always mean that the limb is completely normal, but the goal is to try to circumvent the functional and physical impairments to the point that people can be productive and happy and coexist with this chronic medical condition. Now, one of the other problems that we face still today in 2018 is getting our healthcare system to pay for all of this. These treatments are not cheap. If you're going to see a lymphedema therapist for 20 to 30 sessions at a cost of $200 per session, that's a lot of money. The pneumatic compression devices may cost as much as $5,000. The garments cost anywhere from $150 to thousands of dollars per year because they have to be replaced depending on whether they're custom or off-the-shelf garments. And the problem is the third-party healthcare system is not well prepared to acknowledge their requirement to deal with this. I do want you to know that there is a grassroots organization that I've been working with since 2009 called the Lymphedema Treatment Act. I strongly encourage you to look them up and get involved with them if you or anybody in your family cares about reimbursement for lymphedema. Here's a deep and dirty secret. When the Medicare legislation went into effect in 1966, somebody forgot to link the diagnosis of lymphedema to the treatment code for a compression garment, which means that all Medicare patients to this day do not receive benefits to pay for their garments, even though it is the central issue in their maintenance care. And there has been legislation before Congress since 2009 to try to change this, because the only way that Medicare can reprogram the computer to link these two things is through an act of Congress. And thus far, that has not been successful. It is on the floor of the Senate and the House again this year. I do know that our senators have signed on to the bill here in California. I have been twice to the House of Representatives to talk to the congressman, but it's really an uphill battle. It is very difficult to get bills like this passed, and we really need the help of the grassroots to make this happen. I want to say just a word about surgical options, which when I was here in 2012 didn't look quite so promising, but have become increasingly so. There are a few things we can talk about. The most important one, in a way, is this one, which we would call a palliative surgery or debulking surgery. It's not meant to improve the lymphatic function of the limb, but I mentioned to you that as lymphedema progresses, there is this sequential deposition of all kinds of things, including a lot of fat. And by the time the patient gets to late stage 2 lymphedema, more than 90% of the extra size of the limb actually is the fat that has been deposited in the limb. And this can be removed surgically through a general anesthetic approach, but one that doesn't even require any incisions. It's all done through cannulas that are inserted directly through the skin. So you can see this patient has had about 4 liters of material removed from the limb, and all of the stuff at the top that's yellow is the fat. The only lymph that was remaining is that little bit down below. But actually, the limb can be restored to a normal size and can be maintained that way pretty much indefinitely if the patient is very assiduous with compression. This does require round-the-clock compression after the surgery because we do nothing to repair the lymphatics. We're just taking away the sponge that is sopping up the extra lymph fluid that used to accumulate, and we need to be sure that doesn't recur. In lipedema, we have a similar technique called Tumescent Liposuction, where the lymphatics are intact, but here we introduce fluid into the tissues, and a little bit like the agitation cycle in your washing machine, we agitate the fat cells from their surrounding connections, and then they're withdrawn with the fluid. It's not a cure-all. It's not a cosmetic procedure, but it does help a lot with mobility and pain and the general problems associated with lipedema. Increasingly, we've been using microvascular techniques as well, and there are a couple that are currently practiced here at Stanford and elsewhere. These surgeries are done under a microscope because the suture that they use typically is so fine you virtually can't see it with the naked eye, and you're working in vessels that are almost impossible to see with the naked eye. One technique involves a kind of a bypass procedure where you take the lymph vessels and connect them directly to the veins. This is called lymphaticovenous anastomosis. And the other one is called vascularized lymph node transfer, where we take a healthy lymph node from another part of the body as part of a skin graft, graft it into the affected limb, and the lymph node serves to orchestrate the repair of those lymphatics and eventually help the patient to become garment independent and, in the best case scenario, to revert to a normal limb. Now, the problem with all of this, of course, is getting doctors interested enough in this to advance this field and to offer these services to their patients. I want to conclude my comments before we have questions with what I call hope for the future. I've already highlighted the book that I'm not expecting anybody here to purchase, not the least of which because it's quite expensive, almost $300. But I'm hoping that doctors will buy this and use this and refurbish their medical knowledge. There is an organization called the International Lymphedema Framework, which has issued a variety of documents since way back in 2010, providing guidelines for various aspects of the diagnosis and treatment of lymphedema and other allied conditions. I have the privilege of serving as editor-in-chief of this peer-reviewed journal, which is considered to be the premier journal for lymphatic biology and lymphatic medicine. It's been in existence now for about 14 years, and the submission rate steadily grows, the circulation rate steadily grows. We've gone from 4 issues a year to 6 issues a year, and I think the fact that people are publishing means that there will be hope for the future. I've had the opportunity to organize a series of conferences at the National Institutes of Health. This is one of those, using the individuals who are intramural investigators at the NIH to promote the lymphatic agenda. And what's most encouraging, we have something called the National Library of Medicine that catalogs all peer-reviewed publications in a central location, and you can see the growth of lymphatic-related publications since about 1940 until I've taken this out to 2015. But this exponential growth, if you were on the board of directors of a company, you would be quite jubilant if this were the profits. But this is the profits of research, basically, and this will hopefully translate into clinical practice. So I'm going to tell you a little bit about what we're doing here at Stanford. We do have, I would certainly say, the biggest research program related to lymphedema, and one of the only ones, actually. The first thing I want to mention is that we have an international registry for lymphedema and lymphatic diseases that is housed on the Stanford campus, and this can be accessed online. Anybody who has a lymphatic problem can enroll in this in a de-identified fashion so that scientists have access to aggregate data for this large patient population that has generally been inaccessible. The biggest virtue of this program is it's linked to a biorepository, so when individuals can give us DNA or tissue specimens or surgical specimens or autopsy specimens or anything that is human tissue that can be studied, that tissue can be discovered through the registry and then sent to investigators anywhere in the world who want to work on human lymphatic problems. So that's the International Lymphatic Disease Registry and Biorepository, and I'll have a slide at the end with the URL for that one and others. Now I want to talk about finding a drug for lymphedema. That's been my dream over the last 15 or more years. And again, I want to remind you that when we're in this stage of lymphedema, there's a lot that we can do. We have a lot of mechanical things and even some drugs that can help to eliminate the accumulation of fluid in the tissues, but unfortunately, most of the lymphedema patients end up like this, and we have no treatment for this. And my thought has always been if we could uncover the mechanisms that contribute to the transition between the first picture and the second picture, then we maybe will have a drug that can reverse that process. So we're reaching for the sky here, but I'm happy to say that I think it's successful. So again, I showed you this outline earlier about the forces that lead to the transition to that late problem, and I became very interested in the component of chronic inflammation. This is something that I began to see in exquisite detail in the animal models that I was working in, and basically we eventually identified some inflammatory pathways that we thought were interesting and appropriate. And now this is in a mouse model of lymphedema, and I want you to see what normal skin looks like in the mouse. So you see this very thin purplish band up at the top, and then the dermis is the pinker area, and then everything down below is muscle and other things. What happens in lymphedema is everything thickens so much that you don't actually even get to see the muscle and all the underlying structures because everything is thickened skin. When we treated with the drug that we chose to reverse this process, within 1 week, not only did the lymphedema disappear in terms of swelling, but when we looked under the microscope, the skin looked completely normal. So this is really what we're talking about. It's taking that structural change with the overgrowth of cells and all of the deposition of abnormal materials and making it reverse through a drug treatment approach. So just to show you that in a little more detail, there's untreated lymphedema on the left, normal on the right, and the treated animal looks pretty close to normal after this is systemic administration of a drug. In mice, we have to give it by injection, but the drug can be given in people by mouth. So we went on to a clinical trial for this drug, and I'm happy to say that this work is now in manuscript form and is actively being submitted for publication after many, many years. We studied in aggregate over 150 patients in various phases of this work, but what we found is that when we use the drug in people, that thickened skin returned to a more normal thickness through the use of the drug. So what we're doing here is using a caliper. This is like the pinch test to see, how fat you are, but in this case, it's about thickness of the skin. This is the same patient before and after. The normal thickness of the skin might be 2 or 3 millimeters. The one on the left is about 35 millimeters, so roughly 10 times normal. And this one is about 4 millimeters, so just barely above normal. This is after 4 months of treatment with the drug. When we look under the microscope at the skin, what I've done here is taken the tissue specimen and post-processed it in Photoshop so you can see a little bit better what we're looking at. Those pink spirals and squiggles are the collagen in the skin, and the black area surrounding them is where all the fluid and protein and all the other material is. And what you'll see is that, again, in this same patient, before and after, you basically bring those collagen fibers closer together as all of the surrounding material disappears under the influence of the drug. And this is what makes the skin more elastic and more normal. So we eventually figured out that we're working in this very, very complex molecular area. I'm not going to talk about this right now, but I do want you to know that we are focused on this molecule, which is called leukotriene B4, and through our work with the other drug, we were able to discover and identify a much more effective and potent drug that specifically targets that LTB4, which we think is what causes the lymphedema progression. This is what a lymphoscintigram looks like in the mouse. I showed you lymphoscintigrams earlier. They were black and white. This is green because it's fluorescent, but the idea is the same. So that's the normal pattern of the lymphatic capillaries, and they form these nice hexagonal interconnecting structures that allow the fluid to percolate. When you create lymphedema and don't treat it, all the fluid spills out into the tissues. You can't see the capillaries anymore. They're basically not there. This is 1 week after using the drug that inhibits the production of that LTB4, and you can see everything has pretty much gone back to normal. So that's very exciting. I will also show you very quickly that I'm not going to show you both panels, but I'll show you the left panel, which is basically, I showed you near-infrared fluorescent lymphography before. This is what it looks like in a mouse tail. And basically what we've done is we've clipped the lymphatics at the point that yellow arrow is. And so this is the body of the mouse. That's the tail where the lymphedema is. And what you'll notice, this is an animal that was treated with the drug. Actually, I'm not sure it projects terribly well for you. I'll try again. You will actually see that the lymphatic collecting vessel appears under the influence of the drug, which does not occur when we use saline as a placebo. I'll see if I can point it out to you. The lighting in here is not so great for this. There it is, up at the top. You see that white stripe that's coming? That's showing that the lymph flow is going back across the obstructed part of the lymphatics into the normal body of the mouse. Well, based on this, we've actually gotten FDA approval to launch a clinical trial. It's a phase 2 trial. We've enrolled about 55 patients in 4 sites internationally. The major site is here at Stanford, but we have 3 other sites. This study will conclude in midsummer. We have enrolled everybody, and almost all the patients are through the trial, and then we'll unblind them. It's a placebo-controlled trial, so stay tuned. If that looks encouraging, then we will proceed with additional testing, and the goal is to get all of this to FDA approval for clinical use. The other project I want to talk about briefly is improving the outcome of lymphatic surgery. I talked to you about vascularized lymph node transfer. The good news is that sometimes it helps very much, but the bad news is sometimes it doesn't help at all. And we know that part of the problem is when you transplant that lymph node, it has to engraft into the circulation of the lymphatics to work. And if it doesn't do that quickly enough, it will die and nothing good happens. So I helped to develop this structure, which we call the BioBridge. That's what it looks like under the naked eye. It looks like a piece of suture, but when you look at it under the electron microscope, it looks like this, it looks like an English muffin, I guess. And just like the butter likes to go where it does on the English muffin, the lymph likes to flow through these channels. This is made of normal human collagen. And we just have taken all the collagen fibers and arranged them in one direction. And this creates a structure that forms a bridge that will allow the transplanted lymph node to connect to the adjacent lymphatic vessels in as short a time as possible. We're able to show, here's what it looks like in a little higher magnification. We've been able to show that it works in a large animal model of lymphedema. We can reverse lymphedema and create appropriate lymphatic reconnections with it. And we now have, again, a clinical study here at Stanford, sponsored by the National Cancer Institute, to look at a group of women following breast cancer treatment who have lymphedema of the arm, who will undergo the lymph node transfer with or without the use of the BioBridge to show that we can improve the outcome. But even more exciting to me about the BioBridge is this, which is that when you take somebody who's had lymphatic damage before they ever develop a lymphatic problem, I think there is the likelihood that the BioBridge, if simply implanted at the time of cancer surgery, will prevent the development of lymphedema. And we've been able to show that actually in a rat model. So this, again, is one of those near-infrared fluorescent imaging techniques. In this case, this is, just to orient you, you might be able to see it vaguely, but these are the hind limbs of the rat. These are the thighs that are sticking out. This is the limb where the lymph node was excised, and the rat also undergoes radiation therapy. But at the time of the surgical excision, we simply placed the BioBridge across the surgical defect. And what you're seeing there is that the lymphatics have very rapidly grown across the pelvis to connect to the lymphatic channels on the other side. Basically, the animal has created a bypass using the BioBridge alone. Now, that's basically like putting a little extra suture in at the time of surgery. We're actually prepared to launch a clinical trial of this as well. It probably will be a multi-center trial in which we simply look at the ability of the BioBridge used at the time of cancer surgery to prevent lymphedema in a cohort of patients that are treated. I'm going to finish by just posting, excuse me, the websites of interest. You can all write down whichever of these you're interested in. I mentioned the Lymphatic Registry, and there is the website of that, where anybody who is interested in enrolling in that in a de-identified way will help to spur the research effort. This is our website for our clinical program and research program here at Stanford, and that's where you'll find any updates you might be looking for about how our research is going. I strongly encourage interaction with the Lymphatic Education and Research Network, which is a wonderful patient resource and social resource, as well as a support for research internationally. And again, a great source of information. They have a wonderful Facebook page, and they're on Twitter, and they also have their own website. And then for those that are interested in lipedema, there is a similar support network called the Lipedema Project, which has wonderful educational resources. So with that, I'm going to conclude my comments. We have time to answer as many questions as folks might have, but thank you very much for your attention. I'll just leave this up in case anybody wants to look at that. Yes?
You mentioned that in flying, the lymphedema gets worse. What can one do about it?
The question is, because flying can provoke lymphedema or make lymphedema worse, what can be done? What we generally recommend is the use of compression garments in the plane, to use it in the plane. Now, I hasten to say that no prospective studies have been done to show the efficacy of that, but it's the one thing we know we can do to prevent the swelling that might become self-perpetuating. So we recommend that the garment be put on prior to the departure of the plane and left on until the plane lands. That's
Even if the flight is like 14 hours?
the length of the question is, even if it's 14 hours, yes, the length of the flight doesn't matter. It can be as much of a problem to fly from here to Sacramento as from here to Beijing. It's about going up and coming down, not how long you're up there.
I'm going to altitude to Peru. Should I leave on the compression item the whole
Are you
time
going
I'm here?
up to Machu Picchu or so? So the question is, traveling to high altitude, like to Peru, what to do with the garment. I think at those very, very high altitudes, I would leave it on all day, every day. I would take it off for sleeping. What I generally recommend to patients who are going to somewhat more modest elevations like Lake Tahoe, which is about 5,000 feet, is that after a period of acclimation of maybe 3 or 4 days, then you can leave the garment off. But up there, that's such high altitude that I think it's really quite worrisome, and I would probably wear it on a daily basis. Yes?
Is LTB4 appropriate at all stages of the lymph?
We think so. Now, I have to qualify that by saying that the forerunner study that we did when I showed you the calipers, that was a drug that also inhibits LTB4, but by a less direct mechanism. In that study, we enrolled all stages of lymphedema, all durations of lymphedema, all causes of lymphedema. And we saw responses across all subgroups. The ULTRA study, of course, we don't have the results yet, but the patient population that was enrolled was a little more restricted. And it's because in order to gain the benefit of an initial study, you want to be sure that the statistical analysis is going to be as fruitful as possible. So you want the patients to resemble one another as much as possible so that you don't have interperson variability that's going to affect the statistics. When we do studies in mice, they're all identical twins of one another. So they're as alike as they possibly can be, and they're all the same gender. We allowed men and women in ULTRA, but they basically had stage 2 lymphedema, but the duration was not a factor. It could be short duration or long duration.
Two-part question. One is there a timeline for when the drug will be available?
The question is there a timeline for the drug availability? Well, It's all based on, number one, what the results look like, what the response of the FDA is to what we tell them, and what they tell us they want to see in the way of additional data. This would not be nobody would consider this a definitive trial yet. In any event, we have to do at least one phase 3 trial, which is a much bigger study. I would say conservatively, we're looking at somewhere between 2 and 5 years.
And the next one was, so I have lymphedema in this part, so my physical therapist thinks. So I do the exercises every day. Is that going to at least maintain, or will it swell more?
So the question is, with a diagnosis of lymphedema and daily exercises, and I assume you mean manual lymphatic drainage, will that maintain it and keep it from getting worse? That's the dogma. That's what we hope is going to be the outcome. But in fact, even that simple premise has never really been prospectively proven, that there's a difference in the rate of progression between subgroups that are treated or untreated. I think it's more the idea that the more that we can preserve lymphatic function, the less the likelihood that the structural changes will occur. But it's not a guarantee, I'm sorry.
So that could keep going to the next stage.
It can, unfortunately, yes. Yes.
Two questions. So I've seen you because I've got lymphedema in both legs from hysterectomy and surgery for cancer. So they took out 13 lymph nodes.
Right.
And I've battled with that physical therapy, and I get down after I'm wrapped and stuff. I mean, I lost 12 pounds in 3 days. But then it comes right back. And then it's like hard to control it with the compression and all that. So when I wear the socks, it seems like the swelling just kind of goes around things, and then I end up with these tight bands at my ankle where there's super pressure, and a tight band underneath my knee. When you get that kind of tight band, is that causing more damage? I mean,
Okay, let me summarize I'm going to generalize your question for the broader audience. The question is, when post-cancer lymphedema is treated by the therapist, and there is a very aggressive response to the initial treatment and weight loss and volume loss that is difficult to maintain because the compression garments create constrictions and don't adequately prevent the reaccumulation of fluid. Let me first of all say that because human limbs are not perfectly symmetrical, there are limitations in how perfectly we can compress. So there's not always going to be a perfect solution. But in my opinion, excuse me, everything hinges on having a garment that successfully accomplishes what you're trying to accomplish, which means that if an off-the-shelf garment creates areas that are over-compressed and under-compressed, then we need to think about a custom garment. If a circular knit garment doesn't provide enough compression, then we need to think about a flat knit garment. If the stockings don't work adequately, then we need to think about some of those more fixed systems that have the Velcro, because they are adjustable and they will allow the relief of the overcompressed and undercompressed areas by simply adjusting the Velcro attachment. So I think there are solutions, but I'm never going to pretend that they're ideal. I also think that this is the realm in which the home pneumatic compression therapies can often be very helpful as well, because they help to, it's a little bit like bringing the therapist into your home, so you don't lose all of the benefit of that therapist interaction that is so successful, because you can keep redoing the treatment on a daily basis at home. Not ideal, but I think these are the best answers that I know.
and then the second question was exercise-wise. I mean, 'cause I've got it in both my legs. I've been trying to get on an elliptic.
Right.
Can that help?
Absolutely. The question is, can exercise help? Absolutely. The number one stimulus to lymphatic function is contraction of the muscles. The worst thing for lymphatic function is sitting and standing in a non-moving position. If somebody could put on a well-crafted pair of compression garments and simply walk around all day, that's the solution. That's the very best thing you can do.
Have you seen any connection between the edema and infections in the blood?
Not in the question is any connections between the lymphedema and infections in the blood. Not unless there is a local infection in the tissue that spreads to the blood, which can happen, but not commonly. In fact, we have more commonly the opposite problem, which is that people who have lymphedema are prone to recurrent bouts of soft tissue infection, sometimes quite severe, and we generally can't recover the organism, not from the skin, not from the blood. It's just very hard to culture it, which is another way of saying is it doesn't get into the blood very often. It can, but it's not a common problem.
I don't know exactly how to pose my question, but can somewhat severe swelling of the legs after 6 months or so and sores appear and biopsies are taken, then thereafter, after a year and a half, it's diagnosed as pyoderma gangrenosum. Now, does that have any relationship with the swelling and lymphedema, or is it separate? Or
So the question is, does a biopsy diagnosis of pyoderma gangrenosum have a relationship to lymphedema? Is that fair? Yes and no. So the one thing I want to say to start with, remember I said at the very beginning that there's all kinds of edema in the body, of which lymphedema is one type. The classic cause of tissue edema in an otherwise healthy person is any form of inflammation. Inflammation makes the capillaries leaky and more fluid ends up in the tissue. So just like if you get stung by a bee, you end up with this big swollen place where the bee stung you, that's edema. If you have pyoderma gangrenosum and you have edema long enough, it can secondarily damage the lymphatics and become a form of secondary lymphedema on the basis of chronic or recurrent infection. So there are many routes to it, but not all edema of a limb means that it's lymphedema. You can say that any edema, the presence of any edema, means that the lymphatics have not done their job optimally because they haven't prevented the edema. But that doesn't mean it's lymphedema yet. It can progress to that. Yes?
I have two questions. The first question is, you talked about biomarkers for lymphedema.
Mhm.
Is there anything for lymphedema in terms of biomarkers?
Well, in a sense, yes. I published some work on this. It goes back more than 5 years now. So we actually identified a series of 6 biomarkers, which, when measured concurrently, with more than 90% accuracy, distinguish lymphedema from non-lymphedema. But I think in contrast to lipedema, where we lack a fundamental understanding of mechanisms, in lymphedema, we both understand a lot about mechanisms and we don't really need anything to substantiate our diagnosis. In other words, lymphedema can be diagnosed accurately through a number of means. Lipedema has no biomarkers at the moment, no imaging tests, no blood tests, no biopsies, nothing. And so a biomarker panel or any specific biomarker would have 2 roles. One would be to give us an insight into the mechanisms, and the other is just to say, is this really lipedema? Because What I didn't mention when I talked about lipedema is the difficulty is there's a lot of overlap between what lipedema looks like and the ways in which women put on extra weight. And sometimes it's not that easy to say, is this a general constitutional obesity, or is this a disease that we're going to call lipedema? Well, obesity is a disease too, it's just a different disease.
My second question was, if you have cancer and lymphedema, you don't have lymphedema for, let's say, 20, 30 years or whatever, maybe it's dormant or whatever, could the onset of heart disease or some other type of diseases kind of, I don't want to say exasperate or bring it out like 30 or 40 years later?
The answer is, so the question is, if you've been treated for cancer and you're at risk for lymphedema but don't have it for 20 years or more, could the advent of another disease like heart disease bring it out? Fair? Yes, but it depends a little bit on the nature of the disease. So I would say if somebody who was at risk for lymphedema, let's say in one arm, developed heart failure so that the pressures in the heart went up and there was a systemic cause of edema formation, that could trigger worsened edema in the limb that was prone to the lymphedema. But not every disease. If you suddenly develop, stomach ulcers, that doesn't necessarily mean that you're going to be more prone to develop lymphedema. It's anything that will stress the lymphatics that are already compromised and already working theoretically as hard as they can and preventing edema. If you add to the stress, if you got somebody's hanging from a window ledge with all 10 fingers and you pry up 2 or 3, they're going to fall, right? And that's really what happens in dormant or subclinical or preclinical lymphedema, and then something else becomes a trigger, like sticking yourself with a knife when you're cooking in the kitchen and your arm's at risk for lymphedema. That's going to initiate a wound repair response that taxes the lymphatics further. They were doing fine yesterday, but now they're being asked to do more than they can do, and then you get into that cycle.
Could it swell then or react more to just that burn or that cut?
So the question is, would it then swell? Yes, then it would, yes. Maybe not that moment, but let's say within 24 hours or in 2 days or something like that. Yes, in the back.
At risk for lymphedema because of cancer treatment, do you follow some of the guidelines that you presented, like going to Tahoe? Would you wear compression garments?
That would be the question is, if you're at risk, should you follow those recommendations? Yes, that would be my strong recommendation. Now, from the numbers I gave you, which say that, let's say you've been treated for breast cancer, 90% of your risk you will realize within the first year. So if you have a 20% lifetime risk and you're now 2 years out, your forward-looking risk is about 2%. It kind of depends on your gambling style, but if it were I, seeing the misery that people go through with lymphedema, I would do the simple things that can prevent even that 2% risk. Yes.
I have a question about, I had breast cancer stage 2A. I'm BRCA1 positive, so I got it pretty young. And I had 13 nodes removed, lots of radiation, and I have a little bit of lymphedema, about like max 3 centimeters at times. I was working through with a physical therapist who kind of diagnosed it, and she didn't do any of the wrapping and stuff. She just prescribed me a sleeve. Is that right? Or is that just saying, oh, we're happy with 3 centimeters and let's put a sleeve on it? Or should I have said, oh, I want to be wrapped?
The question is diagnosis of, I'll call it mild lymphedema, by a lymphedema therapist, 3 centimeter size difference, and the treatment was just the placement of a garment without any other physical therapies. I don't know that a mild lymphedema like that mandates multi-layer bandaging, but I would certainly try courses of MLD to see what the responsiveness is, to make sure that the garment that's fitted is able to maintain the minimal limb volume. Because as I've said, what she's given you is ensuring that you will theoretically be no bigger than 3 centimeters, but it's not doing anything to, you know.
And do you have a list of approved, like, lymphedema massage people? Because I went to her to ask, and she said she didn't really know of anybody.
Why don't you talk to me offline and I'll see where you live? And yes, we do. We generally, so one of, the question was whether I have lymphedema therapists approved list. One of the problems is that given the dearth of physicians who are willing to make the diagnosis, physical therapists have gotten into the habit of making the diagnosis and prescribing the treatment. And quite honestly, it is not within the purview of training in physical therapy to establish diagnosis. And so I have a bit of a problem with that, and I have a bit of problem with allied healthcare professionals working in a vacuum without somebody guiding the therapy. So what we prefer to do is to do an evaluation and then tell the therapist what to do instead of having the therapist make the decision. But in most communities, what you're describing is the norm, unfortunately.
And I've been to 3 different, sort of to answer her question, 3 different physical therapists, and the drainage exercise is completely different.
Mm-hmm.
All 3 had a completely different training. So that's confusing too.
So the statement was treatment by 3 different therapists had a very different technique and maybe results from manual therapies. I agree. There are different schools of physical therapy practice. And this form of treatment is as much an art as it is a science. And I think we'll say there are good therapists and better therapists, let's say it that way. Again, I'm not going to, since this is going to another, 50,000 people or whatever, I'm not going to say anything incriminating, but there are various strategies that I think are more successful than others. And that's why I like to select where I send patients, knowing what's going to happen, guiding the therapist in exactly what I would like them to do. It's a partnership. I rely on their hands, but I also rely on their willingness to have me say, this is what I would like you to do.
You mentioned the machines, and I have the two. And the first one was the leg alone, and I think I was in one of your studies.
Yes.
The only thing it did is push the lymph node, I guess, up, and I have lymphedema now much higher than I had before. So I got the whole
Yes.
body, and I'm
Yes.
just wondering, it takes an hour in the morning, an hour in the evening. How effective are they really? I don't see the effect besides taking a chunk of your time and very, very uncomfortable.
I don't know specifically which device. Sorry, I need to rephrase the question. Initial prescription of a leg-only pneumatic compression device created lymphedema in the abdomen. So there was a progression to the style that includes the abdomen in the pneumatic treatment. 2 hours a day of treatment. Is it worth it? It's uncomfortable. Does it accomplish anything? Is that fair?
Does it help? Or does
I
it
just want to make sure
provide
I just want to make sure I stated your question correctly. In the same way that going to the physical therapist doesn't cure the lymphedema and won't create a lasting result without the garment, the same thing is true of the pneumatic compression device. It is a recurring intervention that's meant to reset things to their basal state. If you're a diabetic and you inject insulin on Monday, you still have to do it on Tuesday because insulin on Monday will help you for Monday. So anything you do with these devices are transient. I don't generally advocate 2 hours a day of self-treatment. That sounds like a lot. What we know from the studies is that mechanistically, the physiologic kinds of pneumatic compression devices do improve function and do improve a lot of measurable endpoints related to the lymphedema. We also know from health outcome studies that they reduce emergency room visits, hospital visits, therapy visits, antibiotic prescriptions, doctor visits, pharmacy costs. So all of those are indirect evidence in big groups of people that you're having a clinical effect that's favorable. Is it worth it for you? That you have to decide on your own experience, because you have the backdrop of having an experience before it, and now you know what your experience is with it. I wouldn't propose to tell you that you should or shouldn't do it. I think for the people that are willing to invest an hour a day, which is typically what I will recommend, that I think it's a favorable thing to do, but not for everybody. Yes, sir, in the back.
Can you comment on the risks associated with having surgery on a lymphedema-affected limb?
The question is, what are the risks of surgery on a lymphedema limb? There is a finite risk with anything that you do to the limb of making it worse. And I think even more important, if you have a lymphedema at-risk limb and operate on it, there's a very strong likelihood that the lymphedema may appear as a consequence of that. So any decision to do surgery or not do surgery is based upon the relative risk-benefit analysis of the need for that surgery itself. I will tell you that I have sent more patients than I can count with leg lymphedema for knee replacements and hip replacements. And yes, it can certainly be done. I will tell you the biggest obstacle is not getting me to agree that it's acceptable. It's getting an orthopedic surgeon to agree to operate on a lymphedema leg. They don't want to do it because it's harder for them and they're worried about the risk of infection and everything else. But if you can find, we're lucky at Stanford, we have surgeons who work in partnership with us. If you can find a surgeon who can do it, I think it's quite acceptable. And if the knee needs to be replaced, it needs to be replaced, and we can get through that. And we can do all the therapy required on the tail end to make sure that the outcome is favorable. So, but if you're talking about something that's purely elective and you're not sure, you know, I have mild carpal tunnel and the doctor wants to do a carpal tunnel release, but I have lymphedema in my arm, should I do it? That's a very individual decision. It really depends, how bad is the carpal tunnel? I'm going to say, don't get a tattoo in the lymphedema limb. That's not a good idea. But, you know, it depends on the medical context. Yeah. Yes?
Are there any other places in the Bay Area that do that surveillance system like you do here?
I believe that they do it at UCSF. They at least do it in research. I don't know if they do it clinically. In the East Bay, the only place that I know of for certain, it's not actually East Bay, it's in Kaiser, Sacramento. So, yeah, no place else in the East Bay that I'm aware of.
And you were saying that 30 to 40% of people with gynecological treatment, is that in the first year? Or
That's, sorry, the percentage for gynecologic surgical outcomes. First of all, it's gynecologic treatment that includes lymph node dissection and or radiation therapy. Right. Yeah. So that's lifetime. Yeah, that's lifetime risk, and 90% of that likely will appear in the first year. So
90%. Okay, so it's the same.
it's roughly the same. Yeah. Sure. Yes.
If you're looking at one-time
Mm-hmm.
Let's say one individual is treated with external beam proton therapy.
Yes.
Is there any difference between that and, let's say, brachytherapy or any other radiation therapies in terms of the lymphedema produced?
The question is, in prostate cancer, is there a difference in the lymphedema risk from external beam radiation versus brachytherapy? I don't know that that has been rigorously looked at. My theoretical answer would be that I think the external beam likely has a larger radiation field and therefore, all things considered, has more capacity to produce lymph node damage. But I certainly have seen prostate patients who have developed lymphedema from either of the two strategies. My guess is that the brachytherapy is a little bit safer.
I don't know if it should be an offline question or not, but the physical therapist diagnosed it, and it happened 4 years after my cancer surgery, and I was recommended to see you.
Mhm.
So I don't know if you have a partner or someone else, because I called your office in January and I can't see you till October. And I'm anxious that is this going to get worse by the time you see me?
That's an embarrassing question.
That's why I said maybe it should be
Yeah.
offline. But
My wife is here and will attest to the fact that I sit in the office for more than 12 hours a day and double book and triple book and quadruple book. But the problem is, I don't work part-time, but we only have 2 clinic days a week. Each day that I'm there, I'm there for 12 hours a day. The problem is I am the only person, not only at Stanford, but probably on the West Coast, and maybe one of a half dozen in the United States. I'm sorry. I hate to make people wait, and almost routinely I walk into the exam room and they say, I've been waiting to see you for 9 months, you know, as if I'm punishing them. But I do, yeah, yeah.
my concern is it can get worse? Should I be anxious or panicked about that?
The question is it going to get worse? Of course I don't know, but I think if you're under care, then you're doing everything that I would likely recommend anyway. I think what we will do together when I get a chance to see you, if I get a chance to see you, is think about if there are other strategies we want to think about beyond the conventional conservative ones, or any other workup that we may want to do. But, I mean, the good news is lymphedema, unless you have cellulitis, it's not a reason that you need to ever go to the emergency room, right? It's not that urgent. It's not that rapidly progressive, which is one reason I guess I can get away with not having anybody else do what I do. I wish I did, but I'm still looking for the person who wants to.
Could an insect bite have caused it?
Could an insect bite have caused it? Anything that traumatizes the skin and needs a wound healing response, it can be a trivial scratch. And you may not know what the stimulus was. The good news is, but not for you, is that when you get past that first year, it's basically telling you that if you're still okay, you're not one of those people that's that prone to be pushed over the edge by something that's so trivial you don't even know what it was, right? Unfortunately, that didn't work for you, but right. But statistically, that's where those statistics come from. The longer you go without a problem, it's basically telling you the more robust your body is at dealing with what's happened to it, and the more of an insult you would need to make it happen. But it's not universally true, unfortunately. Yes.
A certain number, I'm new to all this, so maybe, but is there a certain number of lymph nodes that have to have been excised in order to?
Yes and no. The question is there a certain number of lymph nodes that you need to excise? The answer is yes and no. On the one hand, I can tell you that breast cancer patients have 2 different kinds of lymphadenectomy. They can have a sentinel node technique, which represents anywhere from 1 to 4 lymph nodes removed, but not more than 4. Anything more than 4 is called a modified radical or a level 2 axillary dissection. People who have sentinel node, meaning 4 or less, have 1/4 of the risk of people than people who have more than 4. So clearly there is a threshold. On the other hand, there is a finite incidence of people who develop lymphedema with excision of as little as one lymph node. So it's a little bit like my answer to the last question. The less lymph nodes you've had taken out, statistically, the lesser the likelihood is that you will have a problem, but there is no absolute dividing line that says below this you're fine and above this you're not. Okay, you've been a really terrific audience. Thank you so much for all your questions. Thank you.